Good evening, everyone. Am I audible to you?
Yes, sir.
Okay, thank you.
Hi, good evening all. Priya, audibility is okay?
Yeah.
Good evening.
Fine, Hemant.
Very good evening.
Should I check if my videos are playing or not, Hemant, the Priya ones?
Yes, Amit?
So we are live, sir.
Okay. It's all right. No, still 4 more minutes.
can-
Is there? No
No,
one has
you
joined
can-
yet.
No, it should not be an issue because as whatever happens on your laptop will happen on the screen. So not to worry on that. Anup, good evening.
Good evening, everyone. I hope
Good
I'm
e-
audible.
Could you repeat your audio, please, Anup?
Hi, good evening.
Yeah, I think that's fine.
Okay,
Slightly, maybe your mic could be a bit more closer if possible.
1 second.
Could we have one more test audio for you, Anup?
Okay, is it any better?
Yeah.
All right, perfect.
Nori, your audio, please. 1 second, please.
Yes, Hemant. Audible? Is it okay?
Yes. Amit, are you okay with the audio, both people?
Yes, sir. Yeah. Loud and clear.
Very nice. Video is clear, Hemant and Priya. Is it okay? How is the frame rate?
Sir, good.
I can see Suman. Hi, Suman. Hi, Sachin. Sachin is also there. Dr. Dinesh Patel from Ahmedabad. Hi to you.
I have stopped sharing mine. So you're going to wait for some time on Hemant or start straight away?
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
Good evening to you all. Welcome to the webinar series of IACI, the second in the series. Today's topic is cardiac CT on TAVI, transaortic valvular implant or TAVR replacement. It's exactly a decade ago Dr. Ashok Sheth in Fortis Escort in February 29, 2011 performed the first TAVI. And it's almost a decade for a country to perform the TAVI procedure. Though it is not taken off the way the Western world has taken off, but we are making a good slow progress with more of the cardiologists getting interested into it, more available hardware for them to image. I think we are doing a decent progress. Today, we have two speakers, one a radiologist to explain the role of what a radiologist can do and should do in his reporting of a TAVI, even though an extra CD is being burnt and given to the company people. It is important for the radiologist to know how to take the measurements of the aorta right from its root till its bifurcation and below. Dr. Nori is going to explain that. And what are the other features a radiologist should mention in the report? Along the time with experience, Dr. Nori has made a wonderful presentation. In between, he will pause and ask our eminent second speaker, Dr. Anup Agarwal, who is a cardiologist who is dedicated himself on not only performing TAVI, but also has become a proctor, a teacher to teach TAVI. He conducts small workshops for his colleagues to know how it is to perform the same. I now invite Dr. Nori on the screen dais. Can I have a CV slide, please? Dr. Nori is a consulting radiologist in Vista Imaging Center, which he owns in Hyderabad, Telangana. An experience of 30 years in radiology, 27 years in academics, having a good clinical and administrative experience with many lectures and publications to his name. His notable achievements, when we asked him, as a humble man, he would say nothing great. And that speaks a lot about you, Dr. Nori. He is also our Vice President of IACI. I welcome you, Dr. Nori.
Thank you, Hemant.
Can I have the slide of Dr. Anup Agarwal, please? Dr. Anup, can we have you on the screen dash, please? Dr. Anup is a young dynamic cardiologist who has done his fellowship in coronary and structure in St. Vince's Hospital, Indianapolis, who is now a consultant cardiologist at Care Hospital in Banjara Hills in Hyderabad. And as told you, he's a proctor for Evolute R transcatheter aortic valve. He is a clinical lead for the TAVR program in the Care Hospital group. He has many publications and lectures, which went on to 3 slides, Anup, to accommodate your area of interest. He also loves to do digital editing and photography. And there's something he said he loves to do is behavioral economics. That is something at the end of the lecture, I'm going to ask him what is behavioral economics. I welcome you both on the screen dais. And I ask Dr. Priya to come on the screen dais, who is a team leader to perform this whole program. Dr. Priya, give a brief introduction of this particular 1.5 hour program, which we're going to conduct. And then we hand over the screen dais to Dr. Nori.
Hello, everyone. So this entire idea of this monthly webinar series is related to advanced topics in field of cardiovascular imaging. I really welcome both eminent speakers, and we wish that every month we'll come up with some or the other new things. And I too also am very excited for the topic. Dr. Nuri?
Yes, thank you, Priya. Thank you very much, IACI, for having me discuss about this particular program of TAVI protocol. Thank you, Anup, for having given your consent to be a part of the this IACI program. Really appreciate your gesture, and I hope all our radiologists will be, and cardiologists also who are there, will benefit a lot with your experience. So this heart valve team approach, I picked it up from one of the consensus statements of European College of Radiology. Anup is already practicing heart valve team in care hospitals. We had a discussion earlier. He told us that there's a team which have their individual roles cut apart, and all of them form give a comprehensive report on whether the patient is feasible or not feasible for a TAVI procedure. Even before that, I would like to thank all the cardiologists and cardiac surgeons for making it a part of their team as they venture into newer advanced treatment modalities. Unless they do something, ask us to give something more than what we are doing, there will not be a stimulus or impetus for a radiologist to learn and move ahead. You want me to report a routine cardiac CT? It's boring now. You have to venture into newer things. Your brain should act. It should stimulate itself. You should start doing newer modalities, reaching better heights, reaching higher levels. So that is what cardiologists and surgeons are stimulating us to learn and help them in treating a patient. Really thank all the cardiologists and surgeons for giving us an opportunity to help them and help their patients in turn. Now, what is TAVI or TAVR, and what is a pre-TAVI CT protocol? Now, transcatheter aortic valve implantation or transcatheter aortic valve replacement is what is the terminology given for TAVI. But for us radiologists, we should call it as technique of aortic valve imaging and radiology. Why I say this is, you are not going to learn about aortic valve and aortic root only to give about TAVI or TAVR procedure. You are going to learn it comprehensively and give it to the surgeons and cardiologists and everyone else who is planning to do a minimal access procedure. Believe me, this particular TAVI protocol has opened up a lot of avenues for many of the cardiologists and surgeons. As a byproduct now, they are asking us to do mitral valve, then valve-in-valve for aortic valve. Probably we don't know, pulmonary valve also will come. So start learning one by one, As they keep advancing, we'll keep advancing in our knowledge. And to have that advancement in knowledge in aortic valve imaging, you need to have some basics. And that basics is what we are going to learn today. We are not touching upon any complicated issues. It is purely acquisition, anatomy, accurate measurements, reporting, and what to look for, what not to look for. This is exactly what we are trying to do in the next couple of minutes, and ably supplemented by Dr. Anup Agarwal's presentation and his experience. So, where does imaging come into this aortic valve replacement? Clinical outcomes have improved based on the thoughtful integration of advanced non-invasive imaging modalities for patient selection, treatment planning, device selection, that means valve selection, and device positioning. It is very important that the device is positioned properly in the exact level of aortic root and aortic valve. That is very important. Anup will tell us subsequently what goes wrong if positioning goes wrong. Then CT is now the gold standard tool for annular sizing. This entire study, this entire presentation is going to be, most important topic is going to be annular sizing. Then determination of risk of annular injury, coronary occlusion, and to provide coplanar fluoroscopic prediction in advance of the procedure. Now, just briefly, a couple of seconds on aortic valve replacement is the modality of choice in all advanced aortic valve stenosis. It improves the patient's symptoms very dramatically, significantly improves the suffering and symptoms of the patient when a surgical aortic valve replacement is done. If you don't do a surgery, these severe aortic stenosis patients, 50% die in 2 years' time. Now, 30 to 40% are not fit for surgery due to high perioperative mortality because they have other diseases, other comorbidities. They are unfit for surgery. So these individuals, and also those individuals who do not want surgery because the treatment is now, this is only a daycare procedure, they have now benefited by TAVI procedure. Then the first publication of expert consensus document on complete tomography imaging in TAVI by SCCT in 2012. It came out in 2012. Now, after this introduction, I leave the dais to Anup Agarwal, the cardiologist with TAVI expertise, to tell something else about philosophy of TAVI, what he thinks, how a TAVI must be reported, and what is the philosophy of TAVI. Dr. Anup, please.
Thank you so much, sir. I'll just take you over through a very brief introduction, and I can chime in whenever it's required. Trying to get my slides up. Just bear with me for a second. Okay, I hope my slides are visible. If you could just confirm that.
Yes, yes.
Okay, perfect. So we'll just go through some of the very basics, and lot of in my first slide, a lot of what I'm saying, Dr. Nori already explained. Why do we worry so much about aortic valve replacement in severe AS? If you look at this slide, people who get operated, or essentially people who get their aortic valve replaced, they lead a very healthy life. There is an initial perioperative mortality. After that, their mortality is very low. They overall survive more than 5 years, 10 years, pretty good, no problem. On the other hand, people who don't get operated, severe AS who should get operated but who don't get operated, they have a very precipitous drop in longevity. So much so that at 2 years, less than 50% of them are alive. So that is why we should be sending patients with severe AS to surgery, because we know this absolute risk difference is unbelievable. These guys should get surgery. What ends up happening is, look at any data set going from all the way mid-90s to late decade of 2010, almost 30 to 50% of patients, they do not undergo surgery. These are the patients who should have undergone surgery, but they don't undergo surgery, even with knowing the fact that surgery is good. And why they don't go for surgery? There is enough of things that we have discussed that why patients don't like to go for surgery. Because surgery does leave a lot to be desired. There is an unfinished business associated with it, which is not really that much substantiative when you talk about the mortality of the disease itself, but it does instill fear and apprehension to patients, all the way from sternotomy to mortality, stroke, length of hospital stay, this prolonged recovery, anticoagulation, rehabilitation, and all those kind of things. They all leave a lot more to be desired to a particular patient. Remember, these are not 30, 40 years old patients. They are in their 60s, 70s, and they come up with various causes, various reasons why they should not get surgery. They underplay their symptoms. They think I'm too old, I have lived my life. Oh, the surgery is too high risk, I wouldn't go for it. Too frail, where they are not able to, physical strength is not that much, poor rehab potential, they don't have social support. You name it. It's a combination of these excuses, sometimes by the patient, sometimes by the referring provider. What ends up is almost 50% of these patients do not get the therapy that they need. This is what we call as a TVT data set from the United States. I just want to take you over just for a little bit. So you look at this blue line. This is isolated surgical aortic valve replacement done annually in the United States from 2012 to 2019. In 2012, on an average, about 30,000 isolated aortic valve replacement case was done, and 62,000 were done as a part of other concomitant surgical cases. You go ahead in time, and if you see, more or less, annual numbers are about the same up till 2017, 2018. So if you combine these two, you would think that, okay, maybe around 90,000 AVRs are done annually in the United States. And remember, this is a population-based disease. This is not an epidemic. This is not a COVID that comes all of a sudden. There is a certain background level of severe AS that exists in the population. That disease is not going to grow. TAVR gets approved in year 2012, where about 4,000 TAVR cases are done. And come back to 2019, about 73,000 TAVR cases are done. If you take total AVR, in year 2012, approximately 90,000 AVRs are done in the United States. In year 2019, 150,000 AVRs are done in the United States. Now, if you look at it, in 7 years, incidence of AS did not increase by 50%, but AVR increased by 50%. And that was primarily taken over by TAVR. These are those 50% patients who had the disease but for some reason or the other, they were not going for therapy. So what TAVR ended up doing was, it actually got those patients to the hospital, gave them a safer, a lower morbidity procedure, and told them, hey, we can give you therapy at a much lower peri-procedural cost. So you come up here and get the therapy done. And that's how these things came. So this unmet need of AVR in severe AS case, that is substantial. And you can imagine what happens in India as well. So this is, in one slide, it sums up how a cardiologist looks at TAVR. These are the patients who have the disease, they don't get treated, and they get in trouble. So that's the overall idea. We'll go over the indications and the measurements as Dr. Nori progresses with his slides. Dr. Nori, on to you, please.
Thank you, Anup. I thought indications, patient selection you are going to take. It's all right, no problem.
I have it. I have all of that. You want me to take now, or do you want me to take later on?
No, please go ahead. Please go ahead.
Okay, so let me finish up that, and then I will save only the cases to be shown at the end as and when needed. Just give me 1 second. Just give me 1 second. I'm pulling up my slides again. Okay, so we'll quickly go over the indications, patient selection, and whatnot, and then we can come to the cases later on. So for us to do TAVR, we first need to have the correct diagnosis. So these patients should have symptoms. They should have severe aortic stenosis or severe AR with some degree of aortic stenosis, or they may have had a previous surgical aortic bioprosthesis which is degenerated now. So in any of these indications, you should be able to offer them a transcatheter aortic valve replacement. So diagnosis has to be correct. Then you need to ask yourself a question that why surgery is less desirable in this particular patient. Either it is because the surgery itself is high risk, they have a life expectancy of less than 20 years, previous sternotomy, and sometimes patient prefer, they say we don't want surgery, we want TAVR. And then once you have that also defined, then you look for fitness for TAVR. So whether this patient is fit for TAVR, can I do TAVR on this patient? And that is where CT comes into play. We need to make sure their annular anatomy is appropriate, and we need to make sure their vascular anatomy is appropriate. And today's discussion is all about this aspect. No TAVR if the patient is eligible for metallic valve, because that means patient's longevity is more than 20 years. And in that case, you don't give them bioprosthetic valve, you give them metallic valve. This is typically in patients with age less than 50 years. Infective endocarditis or any other concurrent infection. And if the patient needs to go for surgery for any other reason, then there is no point doing TAVR and then sending for surgery. You go for surgery and get everything taken care of. These are some of the common access sites that we use. And the most common access site we use is transfemoral. If you look at all the data set, the mortality benefit of TAVR over surgery is in transfemoral data set. And more than 95% of the cases are currently done using transfemoral. But sometimes based upon your CT assessment, if you tell us that, the iliofemoral system is very bad and the catheter won't go, then we have to look for alternate access. And the alternate access could be transaxillary, transcarotid, direct aortic, or transaxillary. And as a radiologist, we all should know what are the alternative access, because the measurement requirements, what a cardiologist expects, are different if you are planning for alternate accesses. The 4 valves which are currently approved in India, one is the Sapien 3 valve. It is a balloon expandable crown-like valve, what we call it, made by the company Edwards Life Sciences. The second one is the Evolute R. This is by Medtronic. It's a self-expandable valve. We call it like a cylinder or an umbrella-shaped device. My valve, which is made in India, it looks and performs exactly like Sapien valve. And this is a purely indigenous made in India valve. Hydra, it to certain degree mimics Evolute valve. It's a self-expandable valve. It was originally designed in Thailand and now is acquired by an Indian company called SMT. So of the 4 valves in India, 2 are owned by Indian company and 2 are owned by multinationals. So these are the 4 valves. From the radiology standpoint, from the procedural standpoint, what we should know is these are on 2 platforms. One is balloon expandable and one is self-expandable, because the way they interact are different and our measurement expectations are different. Typically, this is the measurement that we look at. Here is a cartoon of a typical annulus that you would see on which an evolute valve is sitting. And when the evolute valve or any transcatheter valve takes up the annular position, you see it displaces the native leaflet onto the side. So what we are looking at is the annular measurement. This is very important because annular measurement decides what size valve we are going to use. Then we have got all the other ancillary measurements like LVOT, sinuses, ST junction. It helps us define how this valve interacts with the aortosinus complex. If you look at it, the wide sinuses, it gives us some room for the blood to flow in diastole. If these sinuses are narrow, then this room is very small and that causes problem. A very important measurement is coronary height. And coronary height is important because this leaflet, if it displaces, it can obstruct coronary. And in this cartoon, you can get a sense of how close is the leaflet length versus the coronary height. That is why accuracy is very important, because if coronary height is even a touch, a millimeter lower than the leaflet height, then this coronary can get occluded when you put a TAVR valve in there. So all these measurements, they require precision at a millimeter or a sub-millimeter level so that we can make a judgment about each patient. Vascular tree, things that you should know is when you crimp a TAVR valve, then mean vascular dimension that is required for that entire assembly to go through is 5.5 millimeters. Remember, the TAVR system can stretch the vessel up to 8 millimeters. So you have to be mindful all the way down. You have to make sure that your vessels are there to accommodate this much size. Remember, a healthy vessel can stretch up to 20%. So if you have a vessel that measures 6 millimeters, then you know it can go 7.2, 7.3 without a problem. On the other hand, if you have vessels with calcification or disease, then you cannot stretch it more than 1:1. And that is again something as a radiologist we should be reporting about what the vessel's overall parameters are. So relevant measurement for the transfemoral axis will look for minimal, maximal, mean diameters, disease, calcification, dissection, tortuosity, everything. Tortuosity, a word of caution, we should report tortuosity both in coronal as well as sagittal plane, because sometimes the vessel may not be that much tortuous in the coronal plane, but if you go sagittal, you see that it dives deep inside the pelvic space. And that gives us a better estimate of how tortuous the vessel is. And we should also comment on common femoral artery bifurcation, because that is our puncture site. So we want to make sure that the bifurcation is at the appropriate level. For the transaxillary, other than the vessel measurement and the tortuosity and disease, one important aspect is we should ask, is lima present? Has left internal memory been used for a previous bypass? If it is used, then it becomes very difficult to do transaxillary TAVR there, because if you injure the lima, the patient gets an MI on the table. And we should always measure the axillary or subclavian artery literally next to or close to the lima origin, so that we know how big is the vessel there. For transcarotid, we are very particular about atherosclerotic disease because it can cause stroke. So we want to make sure this artery, if we are going through this route, is free of any atherosclerotic disease. For direct aortic, it's interesting because direct aortic, a surgeon gives us an access. So we have to make sure that there is no vein graft present. If this patient underwent CABG before, there should be no vein graft coming from that edge of the aorta where we are going to poke our catheter to do the TAVR procedure. And we need about 60 millimeter of space from the puncture site in the ascending aorta and the annulus. So in the CT scan, we should mark how much is the 60 millimeters from the annulus cephalad and see whether that area is free of any vein graft or anything where we can puncture. So these are kind of some of the nitty-gritties of of alternative accesses. Annular measurement is very important. This we will talk. I'm not going to go into individual details. We will talk as the way goes. But annular measurement is very, very important and is the most critical part of CT assessment. And I will briefly mention as required in terms of what are the other nitty-gritties. But most important, we need diameters, both area derived diameters and perimeter derived diameters. This we will talk over the slide. This is in summary what a TAVR workup is. We do history and physical. We need to make sure there is no other problem. Basic laboratory assessment, ECG, echocardiogram, and then the CT TAVR. This is the crux of TAVR assessment. We do coronary angiogram in those patients where we have some suspicion that they have coronary artery disease. If they have dyspnea, we do dyspnea workup. If patients have dizziness, they get dizziness workup, and they get dental assessment to make sure they don't have any infection. So this is in a nutshell how cardiologist looks at TAVR. And after this, I can show you some representative images as we go along in the discussion. So Dr. Nori, on to you.
Thank you, Anup. Thank you for a very neat initial presentation. Now that we have finished with the cardiologist presentation about indications and everything else, what was supposed to be in the initial part of the workup, let us go straight into what next comes after the diagnosis of aortic stenosis. How do you assess the severity? Basically, 2D echo is the primary imaging modality of choice for assessing the severity of aortic stenosis. Does radiology have a role anywhere? Yes. Calcium score, CT calcium score, just like you do for coronaries, you do for aortic valve, and it has been postulated that if the calcium score of aortic valve is more than 2000 in men and more than 1200 in women, it makes aortic stenosis, severe aortic stenosis, more likely, highly likely in those individuals. Now, what is the role of MRI? MRI is an alternative in those individuals who have got renal dysfunction, contrast allergy, and other things which are not feasible for CT scan. MRI can be done. But MRI, as you know, at 78 years of age, with arrhythmias, with breathing difficulties, so many other complications, kyphoscoliosis, it is not easy for an MRI to be performed and to get the same accurate measurements as what a CT scan gives. So MRI can be an alternative because it can look at the aortic valve opening area, transvalvular velocities, planimetry, phase contrast imaging, and LVEF calculation simultaneously. But ultimately, the crux, the bottom line of annular measurement, calcification, and other aortic root and valve assessment, CT is probably much more superior than an MRI. So a combination of MRI for measurement of the velocities, opening area, other anatomy, and plain CT for calcium is a good combination to go for a TAVI if the surgery is very much contraindicated. Now, what is the normal measurement? Just to know, we can do planimetry ourselves in systole. When it opens, the aortic valve opens in systole, you can measure. And if the aortic valve area normal is up to 2.5 to 6, severe if less than 1 square centimeter, moderate if it's 1 to 1.5 square centimeter, mild if it is 2.5 to 1.5 square centimeter. So that is what is the severity we can measure even on CT scan. Now, what is the goal of pre-TAVI CT? What is the goal? What exactly are you looking at in doing a pre-TAVI CT scan? The goal is to provide motion-free, high-quality images of aortic valvular complex and root, that is, aortic valve annulus, commissures, sinus of Valsalva, osteo of coronary arteries, sinotubular junction, combined with a large longitudinal coverage encompassing the entire aortic course between proximal supraortic vessels and iliofemoral axis for axis evaluation. So ultimately, you are going to give everything about the aortic root, valve complex anatomy, and also the entire length of aorta from supraortic vessels to femoral arteries. That is very important. Now the challenges are patients are obviously 78 years old. They've got shortness of breath, arrhythmias, renal dysfunction. It is for you and your team to get good quality study. So this is what we are trying to look at. Is initial study, initial phase. The phase 1 is a ECG gated helical acquisition. You no need to do so much. You can even do just the ascending aorta and root. But if the patient is okay, you can do this, and same contrast injection. Again, you do a follow through from supraaortic vessels to the level of lesser trochanter or slightly below for the access. So this is what a cardiologist needs before planning his TAVI procedure and before selecting a patient for TAVI procedure. So now let's go into the technique. How do you do the technique? Standard technique. And wherever I put these asterisks, those are important slides, and you should pay much more attention than routine slides. So calcium score plain study is optional. It is institutional based. You do, don't do, it's up to you. If you do also, it's okay. Don't do, it's all right. Now, the first phase is ECG gated helical for less than 256 scanners. And for whole heart scanners, you just do an axial study, because those scanners which can do a volume single beat heart, entire heart volume, it's an axial study. But for all other scanners which have got a 4 centimeter detector row, those you do ECG gated helical study of aortic root and ascending aorta. Then coming to prospective or retrospective gating. Now, the concept of retrospective or prospective gating is very important, because when you look at the aortic valve dimensions, an analysis of the aortic root and aortic annulus, most important we have to look at is the systolic and diastolic phases. In the systolic phases, we have to look at the annulus is measured in the systolic phase, and the rest of the aortic root, valve and sinuses are measured in the diastolic phase. So it is very ideal to get systolic and diastolic phases images. So retrospective gating is very, very important. Prospective gating, if you use prospective gating in those high pitch helical equipment with axial acquisition, there you can have a white padding so that you get some amount of systole and some amount of diastole, or if you're acquiring only in systole, white padding so that you've got a percentage of the systolic phase or a diastolic phase on either side of the where you have fixed the reconstruction or acquisition, so that you have some leverage if there is a movement artifact, or if there is a sudden arrhythmia, or if there is other issue regarding gating, then you have some other phases to fall back upon. Or else you lose the entire study and you have to repeat the study, which is very, very costly, not in the monetary aspect, but for contrast and other things. So that is why usually a retrospective gating is very good with acquisition in entire cycle, systolic and diastolic phases. Then comes 4 centimeters versus 6 centimeter detectors. And I've already told you, you can use high pitch helical equipment, single heartbeat, entire study you can do from acquire from supraaortic vessels to the femoral arteries. Now, the next phase of the study is a non-gated CTA or runoff study using the same contrast for thoracoabdominal aorta, including the supraaortic vessels and proximal femoral arteries. This acts like a roadmap. I've already shown you the image. Now, this study can be done at second run, can be done at highest pitch available on the equipment. That means on your equipment, if it's 1.5, 1.5, 1.9, 2, 2.5, whatever it is, this is only a survey and to get the good analysis of the vasculature from brachiocephalic vessels to femoral arteries, roadmap. So you can use a very high pitch. As a matter of fact, I don't even ask for breath hold in this study. No need for breath hold also. Same contrast, high pitch, you get the entire vessels. Now, important point here is NTG has to be contraindicated. This is contraindicated, or your patient will drop dead on the table itself. NTG is contraindicated. Beta blockers are usually not given. As a matter of fact, beta blockers are contraindicated in aortic stenosis, more so in severe aortic stenosis. Contrast, depending upon the scanner, depending upon the size of the patient, depending upon the heart rate, anywhere between 90 to 100 ml is more practical. It is more practical 90 to 100 ml, but you can go down up to 60, 70 ml. And in patients with renal compromise, you can go down up to 40, 50 ml. You can try, nothing wrong. But ideally speaking, to get good quality study, about 90 ml at 4 ml per second. Antecubital vein, bolus stacking on ROA on ascending aorta, single contrast injection saline chase, and heart rate is not very an issue because you are not looking at coronaries. But when you're looking at coronaries, a 75 to 80 beat per heart minute is good on a 64 and 128 scanners. And usually the proximal coronaries are what is more than enough to be commented upon for the cardiologist. And reconstructions are done from 25 to 45 at 5% intervals for analysis of the annulus sizing, because the best and the largest dimension of the aortic annulus is the systolic phase at 30%, 35%, and rest all can be done at 70% of cardiac cycle. That is aortic root, and aortic wall estimate can be done at 45 or 75% of cardiac cycle. Now, this is just a video showing the patient run up there, and this is the FOV for your first run, that is ECG gated, and that entire FOV is the one for the second run, which is done automatically immediately after the study. You do the second run. So that is very important. You maintain that the second run always includes from supraaortic vessels to the femoral arteries. Now, before jumping into the anatomy, let us have an idea of basic recap, revision, or knowledge. It's all right. If you don't know, we'll learn. If you already know, let's revise about the anatomy and glossary and identification of the aortic valve, aortic root complex. Aortic valve has 4 key parts. Aortic annulus is the one which is most important for today's discussion. It is a virtual functioning ring-like structure on a 3D plane that anchors the base hinge points of the aortic leaflets. It is not a fibrotic band. It doesn't have any muscle. It is only a virtual base ring. We call it as virtual base ring, where the 3 hinge points of the aortic leaflets go and attach at the LVOT. That is known as aortic annulus. It is a virtual base ring in a 3-dimensional, not a 2-dimensional, but in a 3-dimensional form. What is aortic root? Aortic root has sinus of Valsalva, sinotubular junction, and part of the ascending aorta. Of course, you have the aortic valve also. Now, sinus of Valsalva are nothing but outward pouches within the aortic root where the coronary arteries arise from, and they are labeled accordingly. Where from the sinus of Valsalva, which gives rise to right coronary, is called right sinus of Valsalva, left coronary left, and non-coronary is no coronary, non-coronary. These act as a reservoir of blood to supplement the coronaries during diastole, and during systole, the outward pouches act as support for the valve leaflets. So in the initial cartoon diagram, what Dr. Anup has shown you, the outpouching is the sinuses of Valsalva, and they act as support for the leaflets and continuous supply of the blood in diastole to the coronary arteries. Cusps or leaflets are the same. Cusps or leaflets are the same. They could be tricuspid, bicuspid, unicuspid, quadricuspid. You have to mention this in your report, and which is not very easy in a difficult patient. Very difficult in all patients. Commissures. What is a commissure? Commissure is nothing but the space or area between each anchored leaflet to the aortic valve. All the 3 leaflets are anchored to the aortic valve, and the space which is found between the adjacent leaflets is the commissure, and they act as support to the base structure of the cusps. What is raphe? Raphe defines the conjoint area of 2 underdeveloped leaflets turning into a malformed commissure between both the leaflets. So a raphe, if it is seen, it is still tricuspid valve, but the 2 leaflets are malformed or underdeveloped and are joined together by what is known as a raphe, and also there is a malformed commissure in between these leaflets. So when no raphe is present, the valve is strictly called bicuspid valve. So remember, look for raphe. If a raphe is there, it's a malformed valve, tricuspid, but there should not be any raphe to call it as a strictly bicuspid valve. Now, this is a diagram of the anatomy, and this is nothing but what we call an MR or what we call in CT as inflow outflow view. Inflow outflow view, and this is a view also known as a double oblique sagittal plane. Double oblique sagittal plane is very important for us to look at the entire anatomy in perspective. You can say in profile, where that is the ascending aorta, left ventricle, and the aortic root forms a conduit between the ascending aorta and the left ventricle. This is the mitral valve. Obviously, there's a continuity between the mitral and aortic valves, and this is the virtual base ring annulus. That is the aortic sinus, and that is the sinotubular junction. Tubular means that it is ascending aorta. So this is the anatomy, and this is what is the plane we have to look at for measurement of the sinotubular junction, the sinuses, something about the annulus, and LVOT. This is the LVOT. The distalmost part is the annulus. Now coming to radiology per se, this is a color VRT showing the aortic sinuses, coronary sinuses. This is the right coronary sinus, that is the non-coronary sinus, that is left coronary sinus. Line diagram showing blue line is the sinotubular junction. These are the three-dimensional planes of the valve cusps, aortic leaflets and cusps. Green plane, green one is the annulus, and that is the ventriculo-arterial junction. So the annulus is slightly more caudal or more towards the LVOT than the actual ventriculo-arterial junction. In a double oblique sagittal plane, now the entire tonight in the next half an hour or so, keep always remembering about double oblique. Double oblique is the kind of mantra today, that all measurements, all demonstrations have to be done in double oblique. It could be double oblique coronal, double oblique sagittal, or double oblique transverse. All of them are in double oblique planes. So this is the double oblique sagittal. Blue line is ST junction corresponding to this. The red one is the length of the height of the sinus, aortic sinus. So this is exactly where the valve is going to sit. And these are the coronary sinuses. The green line is the annulus. Now, at this level, when we are taking cross section, mind you, that is double oblique cross section, double oblique transverse section. At the level of ST junction, the aorta looks more circular. At the level of the aortic valve and the sinus, it is clover leaf-like. And as you come down, these are the three cusps which are marked here, are the three cusps. So how do you identify the annular plane? Now we are going to change the terminology. We're not going to talk annulus. We're going to call it as annular plane, because annulus is a virtual base ring. It is only the plane. So annular plane is identified as you go downwards towards LVOT. Once these hinge points or once these dots of the cusps disappear, the next plane is the annular plane. That is the annular plane. And mind you, all these measurements are, this is double oblique sagittal, these are double oblique transverse plane. Without that, you will not get this depiction. So this is circumference, this is circular, clover leaf-like, again going to oval, and annular plane is oval. This is the anatomy. Double oblique plane is the mantra for this slide. Demonstration of annulus and LVOT is done in these projections. Now, this is again like I have shown you the anatomy image, inlet, outlet view, mitral valve, LV, LVOT, septum, aortic valve, sinotubular junction. These are the sinuses, coronary ostia, annulus. The only single plane, but annulus we have to measure in 3 dimensions. That is why. So now this is a normal aortic valve. Systole opened up completely, diastole closed completely. Aortic valve in diastole is not closing. There is coaptation, not complete coaptation, aortic regurgitation. Normal, it is opened up in systole, closed in diastole. Just a movie I wanted to show. Now, what are the dimensions? Annulus in men, 3.1 centimeters, women 2.6, Valsalva sinuses 4, 3.6, sinotubular junction 3.6, 3.2. Now, we'll go to the practical imaging approach to pre-TAVI CT. 5 A's, remember 5 A's, 5 A's and 1 C. 5 A's are annulus sizing, aortic root evaluation, which contains valve, coronary sinuses, and ostia. Then access route evaluation. If they have to put a valve, you need access, good access. And mind you, when a 14 French is put, you are almost taking about 5 to 5.5 millimeters of diameter you need. So you have to measure all the access routes. Then what happens to aorta, ascending aorta, arch, descending, rest of the aorta? That is again access, your retrograde puncture, retrograde going from the aorta. Look at the aorta, then vessels. Then ancillary findings are survey of chest and abdomen, vascular and non-vascular. You have to look for every minor detail in the lungs, in the abdomen, renal artery stenosis, renal masses, liver masses, lung malignancy. Remember, these individuals are 70, 80 years old. They are likely to develop any malignancy, other complications, other comorbids. So all these things we have to mention, so we have to observe and mention. And the last one is calculation of the fluoroscopic angle, which automatically comes when you start doing the procedure. You have to calculate and give the fluoroscopic angle. For them to deploy the valve, you need to give an angle so that on table the radiation time is less, the contrast usage is less. So these are the ones, remember, are very important in trying to assess a pre-TAVI evaluation. Analyst sizing. Everything in analyst sizing, because analyst size is the one which determines the entire TAVI, pre-TAVI protocol. Entire thing is analyst sizing. Almost 60%, 40% is rest of it. So analyst sizing, remember, is done in systole, because the analyst is largest dimension occurs in systole, not in diastole, and 30 to 40% of the cycle. So you identify reconstruction of the phases. You look in your workstation, identify the largest annular dimension, and that is systole. Choose that phase for measuring the dimension. Then care must be taken to see that sharp depiction of the annular contour. Even it could be 35, 25, or 40, but make sure that in systole it must be sharp depiction of the annular contour is very important. Double contours and blur are to be avoided when you are trying to see that the challenge is between man and machine. Man should do what all a machine does. You think like a machine and give your best, the best shot. In the best shot, all these are tricks, tips and tricks to give a best shot. Try to avoid the blurred contours or double blur. Then annular plane is identified, like I told you, by connecting the three lowest most insertion points of the itogal leaflets. I've shown you in the diagram there earlier on. Now, how do you measure? What measure? Short and long axis dimensions, systolic measurements. Then among this, with this you get an average diameter. Then perimeter in double oblique annular plane. All measurements are done in double oblique planes. All measurements of annulus are done in double oblique transverse plane. Short and long axis, perimeter or circumference, area in millimeter square. Now, what are the available techniques you have? One is manually using MPRs, double oblique planes. Other is software based. Automatic, semi-automatic. Automatic, you just give the basic basal hinge points to the marker points. Automatically the software will give you all the details. Semi-automatic, by means of automated software based anatomical segmentation. After segmentation is done, with verification by trained observer and manual correction wherever required, you can do the annulus sizing. Now, why is it very important to assess this annulus, sizing of annulus? Because the accurate sizing of the transaortic heart valve and type of the valve, balloon valve or self-expandable valve, depends upon the annular sizing. Then area of annulus is used to size all the balloon expandable valves, and perimeter for self-expandable valve. Now, when does annular rupture, the dreaded complication, occur? When the presence of moderate or severe subannular calcifications, which I'm going to show and also give you a detail about what all to comment about. Particularly below the non-coronary cusp. If the non-coronary cusp, below non-coronary cusp, on the subannular level, if there are calcifications, chunky calcifications, the prone for rupture. And commonly balloon valves are more prone for annular rupture than the self-expandable valves. Oversizing, if it is oversizing, is estimation is more, then again there's a valve, there's a problem of the annular rupture. And so that is why modification of the annular size is based upon root calcification. Also, the modification occurs on the sizing of the valve. Now, annular sizing, I'm going to show a small video about manual on the MPRs. So just look at this. I have taken a 35% systole, 35%. That is systole, early to mid systole. And this is a coronal plane. On a coronal plane, I have taken the crosshairs exactly perpendicular to the aortic valve. This is a double oblique sagittal plane, double oblique coronal plane, double oblique transverse plane, double oblique transverse plane. Now, go up and down, look at the costia, come down, make that all three sinuses are symmetrical, all three sinuses are symmetrical. Once they are symmetrical, come down, come down, come down. Again, double check. that you are not adding any of the sinus, then start measuring at that level. You will be very lucky if you get all three sinuses symmetrical. They are not symmetrical. In a three-dimensional plane, they are not symmetrical. That is why a software, automated software annular measurement is far superior, I mean, by 1 or 2 millimeters when compared to the manual measurement. The two manual measurement must be done perfectly, precisely. Initially, I have done 2 measurements, long axis and short axis. Now I am doing an area. And remember, here, when you draw this plane, your dots must be very, very close to each other. If the dots are very long and distant apart from each other, measurement will go wrong. So make sure that when you do the measurement, the dots are very close to each other so that measurement is more accurate. You will not get any zagged margins, irregular margins you will not get, and relatively smooth margins you get when you use multiple number of dots, and spacing between the dots is very less, so that you get, now I am drawing the perimeter. Perimeter I am drawing. You get very smooth picture, very smooth presentation, and your dimensions are as accurate as what a machine does. Now, that is what I have shown you about manual measurement. Let us see what happens in a semi-automated thing available in the what I use is a G Advantage software, where there is a special program for TAVI, and I have chosen 25 to 45 sections there, phases there. And once you load it into the software, the segmentation of the iota valve aortic root is done automatically by the software. That is the beauty, and your time is saved, and reproduction rate is much higher. Now it is already segmented. Now what I'm trying to do is trying to check the annular plane. I'm trying to manipulate so that I get the good annular plane, like what I told you, the lowermost point of the hinge point of the sinuses. Once that disappears, the next slide is the one where, or next slide is the one where you have to measure the annulus. Now I am drawing the annulus. See, earlier that was a spline method, but in the software it is a drawing method, and you can edit the drawing also, so that you get smooth margins. You can exactly approximate everything to the enhanced area, to the aortic annulus only, and do not involve any surrounding structures. I am editing. Now this is very important, because this is time taking and very, very important. Very, very important. I suggest that radiologist does it. Don't give it to your technologist. If a very good technologist is there, he will learn. He will help you for some time, but he'll jump off after 5 or 6 months for a better salary. So you should know it very well, and then you should be at the back of it. Now I have got a perimeter, I have got the area there, and perimeter dimensions are already there. The dimensions are already there. Okay. Now coming to the other dimensions. Once you click the diameters here in the software, I get the diameters of the entire aorta. You have seen that entire aorta, entire thoracic aorta dimensions are automatically taken by the software, and these dimensions are always 2 dimensions, perpendicular to each other along the long axis of the vessel. See, there are 2 dimensions, minimum, maximum. All are minimum, maximum. 2 dimensions are there here. Minimum, maximum dimensions are there. You can look at the entire aorta. Now after that, I'll come to look at the ostial heights. How do you measure the ostial heights? Very, very, very important point here. Ostial heights are always measured from the annular plane. Now, if you have seen here, and even in the manual measurement, I have never shifted from the annular plane. You always keep the annular plane like that. Just freeze the annular plane, and all these measurements are done from the annular plane. That is very important. If you lose the annular plane, go back to it again and come and do the annular plane properly. So when you measure the coronary ostia from the annular plane, you measure the annular plane from the ostia. You measure from the annular plane the perpendicular from the annular plane. You have the perpendicular diameter from the annular plane. That is very important. Now, after the ostia measurement is done, we'll try to look at the measurement of the coronary sinus. Now, how do you measure the coronary sinus? Coronary sinus, or the aortic root now, aortic root per se, is measured from either average of 3 dimensions of the maximum dimension of symmetrically appearing coronary sinuses at the aortic root. I have taken 3 dimensions. The dimensions are from the cusp to opposite commissure, and cusp to opposite commissure. So always you use from cusp to commissure dimension, single largest or average the 3, average all the 3 and give the best dimension there. So this is how you measure the aortic root at the level of the cusps, symmetric maximum dimension. Then I'll show you some example again of the annular height measurement, the ostial height measurement. This is the ostial height measurement perpendicular from annular plane to the base of the ostium. It should not include the apex of the ostium, the base of the ostium. That is very important. Mind you, base of the ostium. Then after doing that, in this software, you get all the measurement, annulus measurement you've got, aortic measurements you've got, LVOT measurements you've got, ostial heights, right 14.2, left you've got, and all these are the measurements in this semi-automated software. And then this software is exported to saved and exported to the cardiologist for assessment and evaluation for the company people to give them the valve size, or they'll do their own. Now, in this color picture also, you can see that you get the diameter of the SC junction, you get diameter of the ascending aorta, so on and so forth. Now, let's go to one more case of this is a 46-year-old male, severe calcific aortic stenosis, LV dysfunction, CTCAG is normal, EF 20%, serum creatinine is 1.6, calcium score of aortic valve is 8,200, heart rate is 110 beats per minute. So this individual, actually after we finished the pre-TAVI CT, he went to his hospital and collapsed. He was revived subsequently, but such severe was aortic stenosis that I got in the ascending aorta at around 45 seconds or 50 seconds after the injection to antecubital vein, I got the contrast in the ascending aorta. Now, this slide, this case I have put up just to show you that look at this calcium protruding into the annulus, chunky calcium protruding into the annulus. So that is dangerous. That is irritating for the cardiologist also. Too much of calcium is not required. So that is why I put up this case where calcium score was 8,200 and nice annular plane we've got, oval nice annular plane drawing. This is the calcium. Now when you are measuring the annulus, you imagine as if there is no calcium there. I have done that. I have not included the calcium. Just go through, it. Imagine as if there is no calcium and extrapolate the annulus on either side and draw the annulus measurement. That is very important there. So once the annulus is done, you take the annulus measurement perfectly. See, I am just trying to extrapolate the measurement of the annulus perimeter, trying to make sure that I am not including or excluding the calcium, just including the calcium there. That is very important. Then after that, you come and then you take the accurate measurements, then go to the heights of the coronary ostia. I've accepted the measurement there. I've got the measurement here. Then I'll go for coronary ostial measurement. I've got the fluoroscopic angle view here, LA over 9 degrees. This is fluoroscopic angle view, LA over 9 degrees. That is fluoroscopic angle what a cardiologist needs. Then you've got the diameters. Then of course I will go to the ostia. Now this is a measurement done on a manual method, on a workstation, manual MPR. And this is done by complete automated software, not the semi-automated what I have shown you in the workstation. Complete automated software by the Medtronic company, and the maximum annulus measurement what they gave was 27, what we gave was 28, 1 millimeter difference. And perimeter of annulus was 76, and what we gave was 77.5, 1.5 millimeter. It makes a difference definitely for the cardiologist. But let us better it by doing much better measurement. Now, once the radiologist gives these measurements and the DICOM CD in 25 to 45 phase and entire aorta first phase and second phase given to the company people, they give you the measurements like this, and the size is annulus is 23 millimeters. So what kind of valve has to be used? Annular diameter is 18-20 millimeters. 23 millimeter valve is used. Similarly, it is annulus diameter is 26 millimeter. This I think Dr. Alup will talk about it. We are not going to it. This is what I've been trying to tell you. It's smooth, it must be smooth. If the margins are jagged or irregular like this, the measurement will go wrong. It will go wrong. Now, in diastole also, you can take annulus, especially when there is septal hypertrophy. When there is septal hypertrophy, because of dynamics of the aortic annulus, in diastole, the better measurement occurs, non-systolic. So always keep open. Retrospective gating is very important in those cases. Now, mention always about the calcification, like I told you, mild, moderate, severe. Mild, single, adherent, not adherent, just adherent but not protruding. Moderate, 2 or more nodules of calcification or a single nodule protruding. This is the annulus level, the subannular level, the subannular, annulus and subannular level. You can see that in LVOT, the calcium is going, chunky calcium is going to LVOT. This is a large calcium going into the annulus, protruding into the annulus. So these are the ones which lead to failure of the procedure and paravalvular leaks or regurgitations. So you have to mention all this in your report. Now, these are known as landing zone calcifications. And landing zone calcification are very important. I have shown you some examples. You mentioned those in your report. Some examples again, going into the LVOT, calcium going into LVOT. This is the calcium is beneath the right coronary sinus. Here the calcium is beneath the left coronary sinus. I request Anup to now give comments about the annular sizing, calcium, and everything else. Anup, your show, please.
I'll take a minute here, please, if you don't mind, Anup, before you take it up. Very important is double oblique. How do you take, if you could answer that question, because that's so important for the radiologist to know. Is there, you have a case where double oblique can be shown? How do you move your cursor before we proceed to Anup, please?
Shall I show it?
Yes, please. Just a few seconds, because that's so important that they should know how to take the double oblique. It's not difficult, but I think once, if you show them, if you have an automated software, the one Nori said, it's fine, but otherwise manually you have to know. Yeah. Yes, please.
This is a simple slide to get a double oblique. On an axial section, draw a line through the center, draw a oblique line perpendicular to the center of the aortic wall. When you draw this, you get a double oblique coronal plane. Coronal plane. Now, on a double oblique coronal plane and also on the transverse plane, you manipulate the angle, manipulate these two crosshairs so that you get a double oblique sagittal plane and a double oblique transverse plane. So this is how you do it, but you still want, I can show it here. Now this is a, you can see here that this is just plain axial sagittal coronal. Now I'm trying to go to double oblique plane. Now you see that I have taken the coronal plane, and this is a double oblique sagittal plane after rotation. This is double oblique. Now, unfortunately, already my slides are in double oblique planes only, and I'll probably go to radiant. I'm going to show anyway one case in the radiant lastly. So then I'll show it actual double oblique. Hemant, I'll show in the on the
that's
radiant.
Great. Yeah, absolutely. No issues. No issues. Absolutely. Anup, on to you. You'll take over now. Just one question I will ask you here. When Dr. Nori said that calcium score is optional, I hope you said it was aortic valve calcification. Nori, am I right when you said that about the calcium score? Calcium score being an optional. Yeah.
Aortic valve complex probably.
Yeah. So Anup, your comment on that particular thing. Do you really need those values?
So, you know, the aortic valve calcium score is a tiebreaker for us whenever we have got some discrepancy in our diagnosis of severe aortic stenosis. This typically happens in patients who have got low LV systolic function or who have a very small LV cavity. Patients who have got concomitant aortic regurgitation. There are a few other situations where we are not quite sure whether we are dealing with severe aortic stenosis or not. And there, the degree of calcification helps us decide whether the patient has severe AS. Now, when you get a requisition for CT TAVR, a best practice or an astute cardiologist would write his diagnosis or her diagnosis. So the cardiologist would say patient has a diagnosed severe aortic stenosis. When that is the case, your calcium score may not add a lot of value. But if the requisition says that patient has got query severe aortic stenosis or moderate aortic stenosis, their calcium score holds a lot of value, because there, if your calcium score in male is more than 2000 or female more than 1200, it is highly suspicious of severe AS. And if those numbers are 3000 and 1600 respectively, then that is almost diagnostic of severe AS. So that is for the calcium score. I do think we should repeat it more frequently, because then we get in a habit of this best practice, so that in a patient where it will really make a difference, we know how to do it, and it becomes like our reflex. I don't know if that makes sense. Did I answer your question, Dr.
Yes,
Ahmed?
yes, yes, sir. Thank you. You can proceed with those points.
Yeah, so the annular measurement is what has been discussed. It's the most critical part of CT assessment, and really the accuracy has to be at the sub-millimeter level. It decides which size of valve we are going to use, which size of balloon we are going to use. So most of the measurements that we are used to is maximum, minimum, and mean. In annular measurement, we don't talk about maximum, minimal, or mean. While we do have those measurements, for us to select the size of the valve, we need derived parameters. So what I mean by that is you calculate perimeter, or you measure perimeter, and you measure area. That is something you have to do very discreetly. It has to be a well traced out measurement. Once you measure the area and the perimeter, you derive your mean diameter based upon those area and perimeter. And these are the numbers that we use to decide which size of valve we are going to use. Which size of balloon we are going to use, that is decided by the minimum diameter, or the diameter where the annulus is most constrained, and the mean diameter of area or perimeter that you have just given us. So between these two measurements, we decide which size of balloon we are going to use. So effectively, whatever we do in the lab is decided by what numbers you give us. And I'm not overstating when I say that 1 millimeter higher and we have a dead patient on the table. 1 millimeter smaller and we have a valve embolizing and flying somewhere in the ascending aorta. So we really don't have much option. When we have got complication in the coronaries, we have chance. We can figure out what to do, what not to do. When you have such complication in the structural case like TAVR, we really don't have much time. So that is why the best is to avoid complication. In fact, if I have to share a historical tidbit with you, the very first TAVR study which got enrolled in year 2009, the only two valves which were available were 23 and 26 millimeter Sapien. And most of the valve measurements were done using echocardiogram, transthoracic, and a TEE. And to a certain degree, we were also doing invasive angiogram. And if you would believe me, there the valve embolization rates were somewhere around 6 to 10%. So 1 in 10, 1 in 15 valves that they would implant would embolize. And similarly, the annular rupture rates were very high. All those numbers came down to almost negligible the moment echo was replaced by CT scan. So to give you an idea of how much CT scan helped us to get that, the accuracy has to be sub-millimeter level, and it has to be reproducible, which means every single time when you take that study, you should get similar numbers, barring just a few decimal points. So we report minimum, maximum, mean, area and area derived diameters, and perimeter derived diameter. This Dr. Nori already covered. For the balloon expandable, it is area. So for balloon or balloon expandable valve, we look at the area and perimeter. A cross check for you, perimeter derived diameter should always be equal to or larger than area derived diameter. So if you have a report where it is the other way around, where if your area derived diameter is larger than your perimeter derived diameter, then you are measuring it wrong. Something somewhere is screwed up. So that is your internal assessment. Your perimeter derived numbers has always to be either same or larger than your area derived diameter. We do calcium assessment. Dr. Nori showed a great example of a calcific nodule, which is sitting there, which is disaster for us. we should see what is the distribution of calcium, leaflet versus annulus versus LVOT versus ST junction. So these are the 4 places where we want to know where the calcium is. Leaflet assessment, how many leaflets are there or cusps are there, whether there are 3, there are 2, there is 1, there are 4. Many of the times in severe AS, the leaflets are destroyed because of calcification and fibrosis. So many of the times it becomes very difficult to ascertain whether it's a trileaflet or a bileaflet pathology. One very important thing, your plane of annulus will define your coronary height. It is very, very important. If you choose your annular plane 2 millimeters below the true annulus, thinking that you are getting a good quality image there, well, when you measure your coronary height will be falsely increased by 2 millimeters. So you may be giving cardiologist a false sense of security that your coronaries are more than 10 millimeters. So let's say if your plane of annulus is that you have got is 2 millimeters below where it is supposed to. And if you report a coronary height of 11 millimeters, more than 10 is what we want. So at 11 millimeters, a cardiologist may feel very safe in implanting a valve, not realizing that your annular, that the plane that you chose for annulus was lower than the true plane. If you would have chosen a true plane, the coronary height in this particular case would be 9 millimeters. And now your entire assessment and your entire procedural planning changes. That will be a fundamental difference between a successful procedure and a dead patient on the table. So all these things, I keep reiterating, has to be at a sub-millimeter accuracy so that as a cardiologist, we can be very confident in what we are doing. And then annulus angle is one thing that we should talk about. Annulus angle is essentially the angle between the annular plane and a virtual horizontal plane. Essentially, what you are trying to see is whether your aortic valve axis, is it more vertical or is it more horizontal? Because remember, your valve is coming from the top. So more vertical the annulus is, easier it will be for the valve to implant. If it is very horizontal, then now you will have a canting. Basically, the valve that you are pushing in will be tilted, will have an angle as compared to the native valve. So this annular angle is also important. Fluoroscopic angle that Dr. Nori mentioned, somebody questioned, somebody put a question in the Q&A. Fluoroscopic angle is that II or image intensifier angle that we are going to use during our procedure to identify a coplanar view. What a coplanar view is, it's a radiographic image where you are able to see all 3 cusps aligned in the same line, and that is not seen in every angle. So essentially what you do is you take your CT images, it's a number that software generates automatically, where it looks at which particular view you get to see all 3 cusps aligned in one single plane. And that view, the software gives you an approximate angle that cardiologist uses to start with when we are doing TAVR. So let's say a CT scan would say LAO 10 caudal 4 as my fluoroscopic angle. So as per CT scan, if I change my II to LAO 10 and caudal 4, that is the best possible scenario for me to get a coplanar view. Now, patients don't lie the same way they lie on the CT table as they lie on the cath table. So that is why those numbers are slightly different when we do the actual procedure as compared to the CT derived. But the CT derived fluoroscopic angle is a very good place to start. So the 2 angles that I want to make sure we understand, one is the fluoroscopic angle, which is the II angle that radiologist tells us to start our procedure with. And then there is an annulus angle, which is the angle between the valve plane or the annular plane and a virtual horizontal plane. And this tells us how easy or difficult it will be for us to do the TAVR. So this is kind of nutshell what annulus is all about. And if there are any particular questions, then I'll be happy to answer. Dr. Hemant.
So when you have this protruding calcification, how difficult it is to get an accurate measurements when you want to be accurate sub-millimeter levels?
Right. So, whenever you have a calcific nodule or when you have a very tough calcium sitting at the annulus or at the LVOT level, remember that annulus will not, that calcium will not move. It will move just a little bit, but when you expand the annulus, every soft tissue will expand, but that calcium will not expand. So what we typically do is we measure in between the calcium. So let's say if a calcium nodule is, let's say 1 millimeter thick, then what we think is, and there is no science behind it, what we think is if we be a little bit aggressive, then this calcium may move about 0.5 millimeter. So whenever we are doing a measurement, we don't exclude calcium altogether, but we don't include it in its entirety. We try to just get about half or what is protruding into the lumen a little bit, thinking that is the amount of calcium I will be able to move when I do my procedure. That is why I tell my colleague cardiologists that whenever you have this kind of anatomy, you look at the image yourself and you ask yourself how much of this calcium you will be able to move during your procedure. And if this calcium is at a very mobile surface, something like on the tip of the leaflet, then that calcium I will include in the measurement because I know I can push that calcium out. It is sitting on the leaflet, I'll be able to push it out. But if there is a calcium which is sitting at the annulus, or if there is a calcium, very heavy chunk of calcium sitting in the leaflet, then I know I may not be able to move that calcium. And there I will have to kind of undersize my valve, because I know otherwise if I size it based upon whatever I'm seeing, I will cause a rupture. So a lot of these things, the proceduralist or the person who is doing has to actually look at the image, see how much it will move, get its orientation, and then decide what measurement or what size valve he's going to choose.
Thank you. Nari, you want to contribute as to how difficult is it as a radiologist to give accurate measurements, particularly when you have a calcification where there's a lot of blooming already taking place? You had mentioned a point that you just go through it
as if it was not there.
Yes.
No, that is
maybe
exactly
when you're showing a radiant, maybe that point you could probably highlight on that.
Actually, that's what has been in the literature also, that the calcium must be ignored and draw the annular plane as it is adjacent to the adjacent annulus. So that is for measurement sake, because that is for standardization. See, the problem now is whatever I'm talking is consensus statement of SCCT 2019. Unless we have a standard dialogue, standard measurement protocol and dialogue, we cannot standardize the results. So this has been mentioned in SCCT that this is how it has to be done. Similarly, all measurements, all angulation, everything has been done as mentioned by the guidelines, within the guidelines. Now, one more point was, for the balloon expandable stent, calcium has an issue because there can be a rupture. But what I was told was, for a self-expandable stent, it conforms around the calcium, and self-expandable stent probably doesn't cause so much danger than when compared to balloon expandable stent. I would like Anup's comments there, please.
Yes, sir. So, theoretically speaking, self-expandable valves should not cause a problem in terms of rupture or whatnot. But what ends up happening is when you have calcium, then that calcium creates a lot of problem. And I'm just trying to see if I can draw a little bit. If you're able to see, please, if you're not able to see, please let me know. So let's say you have got an annulus and you have got a calcium sitting somewhere here. Let's say if this is your calcific nodule. Are you able to see what I'm drawing?
Yes, yes.
Yes.
Okay. All right, perfect. So basically, now let's say if you put a balloon expandable valve here, that balloon expandable valve may try to push this calcium out. But because this calcium is fixed, this calcium is not going to come out. So essentially what will happen is this side of the wall is going to be pushed out far more. And you have done a measurement this much. So essentially a balloon expandable valve will be implanted like this. And if it gets implanted like this, there is too much of stress or too much of stretch on this side of the annular wall. And this side of the annular wall ends up rupturing. That is typically what happens with the balloon expandable valve. Now, what happens with the self-expandable valve is something different. With the self-expandable valve, let's say if you have got an annulus like this, and if you have a calcific nodule sitting somewhere here, the self-expandable valve will confirm to wherever it can. So what will happen is the self-expandable valve, even if you oversize it a lot, doesn't matter. It will not expand, it will just sit there. So basically what will happen is the self-expandable valve will confirm to all this area, no matter how much oversize you have done. But the valve is not going to do this. Valve will never do this. It doesn't have the capability to do this. What it ends up doing is something like this. Let's say if you have a calcific nodule here, what it ends up doing is something like this, where it just kind of keeps the nodule out and stays like this. So this is your annulus. This is how a self-expandable valve is going to implant. The problem what will happen in self-expandable valve is you are going to have paravalvular leak. You are going to have leaks here. These will be the gaps which will be formed because of asymmetrical expansion. So essentially what you end up doing then is you end up post-dilating these valves. So you take a balloon, and this balloon you can size based upon whatever you have got left. That is where you looking at the CT and getting this measurement is important. Remember, we don't report this measurement. We don't report measurement between the tip of the calcium nodule and the contralateral wall. But if you have this measurement, then you know if you take a balloon, maybe 1 millimeter bigger than this, then you will be able to push this calcium just a little bit out, still not risking the rupture. And maybe this will allow the valve to kind of, sit a little bit more inside, and you will reduce the leak. So to summarize, you will have, if you have calcific nodule with balloon expandable valve, you run the risk of rupture. With the self-expandable valve, you run the risk of paravalvular leak. And if you aggressively post-dilate a self-expandable valve, then you can get rupture like how you get in balloon expandable valve, because at the end of the day, there is a forceful pressure that is applied to that calcium nodule. So any balloon can cause problem.
So
Thank
do you at times don't do a TAVR because you find the protruding calcification is more than what you think you can salvage?
Absolutely, 100%. And that is one of the TAVR candidacy that we look at. If you have patient with severe calcium where you think you are not going to get an optimal result, then that patient should explore a surgical option. Now, there are at times, I have a case I can show you where we see severe calcium, we see calcium which is not favorable to us, but we still do TAVR because surgery is not an option. And there you expect some degree of paravalvular leak, and you tell yourself that, you will be accepting that. You cannot aim for a perfection in that case. Remember, you are always trading off some paravalvular leak with annular rupture. And some paravalvular leak means patient will have some degree of heart failure later on. But annular rupture means patient will not come out of the cath lab. So that is the kind of trade-off that you sometimes have when you have that calcium. So a 60-year-old guy comes to you for TAVR, there is severe calcium, send for surgery. Don't do TAVR. It is unethical. Make sense?
Great. Good point. Thank you, Dr. Nori, please proceed. When you are coming on the radiant, I would like you to demonstrate along with double obliques, how do you, if someone doesn't have a software to measure fluoroscopic angle, is there a way manually you could guide the cardiologist on that. So that can happen for all those people who have given this query on the fluoroscopic and annular angles when he opens up the Radiant software during the double oblique demonstration.
Okay, Hemant. Now let me show the how to do the double oblique here. I open the Radiant and I've loaded 5 phases: 25, 30, 35, 40, 45. So I always do at 30, 35. So where the you get the it's a systole, and always and again the annulus measurement is the one of the most reproducible at 35. So we choose the 35. We go to this 3D MPR. Now you got just plain axial sagittal coronal planes. So now what we are going to come to the aortic valve. You adjust the cursor on the hair on the crosshair on the coronal plane perpendicular to the LVOT or aortic valve and intersecting the aortic apex. Sorry, ventricular apex, LV apex. This is one. Now, once this is done, you get all 3 planes here: double oblique transverse, double oblique sagittal. On the double oblique sagittal, you try to adjust again in such that the entire ascending aortic root, ascending aorta, and LVOT are aligned in a single plane, and the other crosshair of the coronal is sitting exactly perpendicular to the aortic valve. So this is the double oblique plane. This is a double oblique sagittal. You've got all 3 here: LV inflow, outflow. This is a double oblique coronal, double oblique axial or transverse. So on double oblique transverse, you can see here this is a bicuspid aortic valve. This has been sent to me by a cardiac surgeon for sizing the annulus, because on 2D echo the annulus size was mentioned as 17 millimeters, but here he wanted to make sure that what exactly is length of the annulus here, dimension of the annulus here. So we have mentioned here the maximum dimension is about 1.88. Other is 1.7. So 1.6, 1.7 is the cutoff for TAVI, and above is, I think, 3.9, 3.4 or 3.2. But here 1.7 versus 1. Together 1.9, 1.7 is coming to somewhere around 1.8. So 1.7 to 1.8, we added 1 more millimeter there. So the surgeon wanted to know exactly the annulus measurement. This is what is exactly you have to do on a double oblique plane, and measure the annulus in the double oblique plane. And this is not for TAVI. This is meant for the typical bicuspid. Look at that bicuspid aortic valve. Look at the typical bicuspid aortic valve, thickened leaflets. So we are not dealing with bicuspid aortic valve today. So it's just to show the double oblique plane and how to get it double oblique plane. I think that puts your question.
Yeah, annular ring. If you can just on that, since you're on that only, if you can just tell them the annular angle on that same 3D MPR. Just take 30 seconds to 1 minute on.
Fluoroscopic angle is again a 3D one, and you cannot. I mean that is always better given on a software on a 3D plane than on this Radiant software and 2D planes. So that angulation,
yeah. So if you don't have that software, you would not be able to.
We'll go for a toss. It'll be wrong actually, because the coplanar is a 3D plane, not a 2D plane. That's an issue. Shall I proceed with my slides now?
Yes, please.
Yeah. So now coming to the second part of it is evaluation of aortic root, that is valve, coronary sinus, and ostial evaluation. So this has to be done best in 60 to 80% of cardiac cycle. Some people have used 45% also. That's also fair enough, because in late diastole or early diastole, it's okay, but should be in diastole. The rest all anatomy, except annulus in systole, rest all anatomy is in diastole. Now you have to measure you have to mention about the valve morphology. I have told you measurement techniques include coronary height, the height of the coronary sinuses, mean diameter of sinus of Valsalva, heights of individual coronary sinuses, height of STJ, and diameter of sinotubular junction. All these have to be mentioned in the report. Now, coronary ostial distance from aortic annulus should be measured in a perpendicular fashion from the established annular plane. So I'll show you the measurements. That is, I show you the measurements. Now, again, we have come to this slide. We will just go into the other slide. How to measure the coronary ostial. Now, this is from the journal. I can show you an example also, but I thought it is easier for it to show. So whenever you start measuring the height of the left or right coronary sinus, it is again measured in these oblique planes, sagittal oblique plane, or coronal oblique plane, and you always fix one crosshair at the annulus. Always maintain that at the annulus, and maintaining that at the annulus, you take from the base of the coronary ostium, from the base of the coronary, from the ostium, from the base of the ostium, perpendicular line to the annular plane. This should not be less than 10 or 12 millimeters. If it is less than 12 or 10 millimeters, it's going to be a catastrophe when you implant a valve, because the leaflets, native leaflets are going to block the coronary ostia. So the measurement prescribed is to measure in the perpendicular plane to up to the base of the sinus, base of the coronary sinus. That is very important. Or the ostium, sorry, base of the ostium, that is very important. Now, sinotubular junction height. Again, this measurement is done from the annular plane, that is the annular plane, to the topmost portion of the sinus or the ST junction. This is the height of the sinotubular junction, and that is exactly where the valve is going to sit. Prosthetic valve is going to sit from the annular plane to now. The coronaries are measured up to the base of the ostium, whereas height of STJ is measured up to ST junction, from the annular plane to the ST junction. Now, sinus of Valsalva diameter. Sinus of Valsalva diameter is again measured parallel to the annular plane. So the annular plane measurements are for the coronary ostia, for the annulus per se, and the coronary sinus of Valsalva. Remember, rest all sinotubular junction, ascending aorta, are the planes perpendicular to the long axis of that particular segment of the aorta. But the sinus of Valsalva are to be measured parallel to the aortic annular plane, and you get a transverse double oblique plane, double oblique transverse plane, get a symmetrical cusps like this. Once you get a symmetrical cusp like this, from the right coronary cusp at 1 o'clock position or 12 o'clock position to the opposite commissure. Similarly, non-coronary cusp at 8 o'clock position to the opposite commissure, and left coronary cusp at 4 o'clock position to the opposite commissure. That is what you measure. Largest diameter you give, or average all the diameters and give. That is the measurement of the sinus of Valsalva, or you can call it as aortic root diameter. Aortic root or sinus of Valsalva diameter at this level is what you give in this particular fashion. That is very important. When you come to sinotubular junction, on double oblique planes, sagittal and coronal have two planes, get the exact transverse oblique plane in the true perpendicular to the long axis of the ascending aorta, or STJ, long axis of STJ here, and get a transverse plane and give the maximum diameter of the STJ on a transverse plane, STJ on a transverse plane, not this, on a transverse plane. Similarly, ascending aorta, again, put your crosshairs on double oblique coronal, double oblique sagittal, have perpendicular to the long axis, make it perpendicular long axis on both planes, get a good circle, give the long axis of the ascending aorta in this plane. This is recommended for TAVI measurement, and I'm sure for all measurements it makes equally as good as for 10 TAVI measurement. So this is recommended by SCCT to do measurements like this. And this I've already shown you this slide, how to get the double oblique plane. And this is given by Medtronic company in one of the cases where we have done. They also have measured like this. Man versus machine is exactly. I mean, there's nothing man versus machine. Everything is recommended. What are recommendations given by SCCT? We are following it, and that gives the best results for the cardiologist. That's what we have to do. Valve, identify bicuspid, tricuspid, or undefinable. Don't be ashamed in telling the cardiologist that I don't know whether it's tricuspid or bicuspid. Don't bluff. That's very, very, very important, because the entire thing, if the cardiologist just overlooks the cuspidity, it's going to be a disaster. So if it's bicuspid, bicuspid, tricuspid, tricuspid, undefinable because of extensive calcification and all sclerosis and non-distensibility of the aortic leaflets, I cannot comment about the cuspidity. Fair enough. Valve calcifications, amount and location, then quantification of leaflet calcification, you can measure and give. Now, aortic root, I've already shown you. I will not go into aortic root measurement here. I'm not going to aortic measurement here for want of time. And measure, grade the calcification of the valve as absent, mild, moderate, severe. Mild, small focal spots not involving commissures. Moderate, large confident calcifications affecting two cusps or small focal spots at all commissures and attachment sites. And severe, large confident calcifications affecting all cusps. So this you have to mention absent, mild, moderate, severe. That is very important. Showing some examples of mild valve calcification. That is a true symmetric position of all the cusps. This is a sagittal double oblique, just showing calcification of the left cusp only there. Now, severe aortic valve calcification, like I have shown the same thing on the in the software movie there. Now, here the calcium is also extending into the LVOT, annulus and subannular plane. Annulus subannular plane. Moderate calcifications involving two leaflets here. Now, this is a quadricuspid aortic valve. Right, left cusp, non-coronary, non-coronary. Quadricuspid aortic valve. Rare complication. I don't know what Anup does for this case, but this is one of the rare anomalies, quadricuspid aortic valve. Now, rarely the aortic valve calcification can extend into the interventricular septum. This one going into interventricular septum like that, and this is a cause for a lot of dysarrhythmias, heart block. Now, coronary ostial height, again important, very important. Coronary ostial height. Why it is important is coronary occlusion post TAVI is 0.66%, as given in the literature, is associated with a poor clinical outcome, and 30-day mortality is up to 40%. Now, 3 points for risk of valve-in-valve procedure, 3% risk, and low coronary ostial height of less than 12 millimeters from the annulus, and sinus of valsalva mean diameter less than 30 millimeters carry an increased risk for coronary occlusion. Already, Anup has told us about a small sinus of valsalva. The native leaflets or the leaflets of the prosthetic valve expand and block the coronary ostia. Now, these of UQ measurement I have told you. You give the measurement perpendicular from the coronary ostia to the base of the ostium. And this is a software picture again showing the measurement of the aortic root at the cusps, the maximum diameter of the cusps, and this is the measurement given. STJ measurement is given here. LUOT dimension is given here. That is a software again. Software in what I am doing gives all these measurements in a proper aligned format, in the proper predetermined format. Now, again, you have to grade this quality of study, good, fair, or poor. You have to grade this study. Good, sharp depiction of annular contour with sufficient contrast attenuation in the absence of artifacts. Less low contrast attenuation, increased image noise is fair, but diagnostic. Poor diagnostic quality, no contrast, literally very low contrast, excessive image noise, motion artifacts, double contours, and pronounced step and stare artifact. And this study, poor quality, avoid that study. We'll finish off and then we'll go to the access route evaluation, then come to Anup for his comment. Now, access route evaluation. Now, access route evaluation, important for radiology is don't do MIPing, don't do MPRs. All are centerline placements and CPRs. Very, very important. It must be centerline placement and CPRs. It must be sub-millimeter, number one. Number two, all measurements are performed perpendicular to the long axis. Very important. Calcification, comment about mild, moderate, severe. Now, tortuosity, you comment about tortuosity in two places like what Anup has said. Now, a tortuous and heavily calcified vessel is much more dangerous than a tortuous non-calcified vessel. Now, always mention about any calcified plaque more than 270 degrees circumference in iliofemoral arteries. This is very, very, very important because that is where the sheath is going to sit and it will cause major catastrophe. So always mention about more than 270 degrees calcium in the iliofemoral arteries. Now, axis root, we'll just see a video just for a couple of minutes. Axis root is important because this is how you have to measure the axis root. Now I have taken an axial section here. Then I am tracing down from aorta, adjusting the window to look at calcium. That is the bifurcation. Will come down up to the femoral arteries. Come down up to the femoral arteries. Then once you come up to the femoral arteries, what you do is you take the advanced vascular analysis or a single or a 2-point view, and then take the advanced vascular analysis and draw the center line. This is a center line identification. Draw the center line. Automatically you have got a center line and measure and give these measurements. Look at the calcium. This is imperative. Either looking at subclavian artery, communicated artery, or femoral artery, or iliac artery. This you have to do. Don't give MIPS. Very, very important. This is very important for you to do the. On a software, you get measurements like this. You get measurements like this on the software what I'm using. You can measurements are all given at this level. See, look at this level, multiple levels. Ascending aorta just above the ostia, distal ascending aorta, between brachiocephalic trunk and left communicated artery, left subclavian artery, proximal descending aorta, descending aorta diaphragm, above the renal arteries, below the renal arteries, at the bifurcation, common iliac arteries, external iliac arteries, common femoral arteries. All these measurements have to be given either in a picture or in the reporting format. Then, these are the same thing. What I have told you is exactly mentioned in the guidelines by SCCT, that how to measure, what to give. All these things have been given, and more importantly, distance from inferior margin of the femoral head to femoral bifurcation. Inferior margin of the femoral head to femoral bifurcation. That is where the puncture site occurs. Puncture site takes place, and that is what that also has to be mentioned. Now, this is what I told you. I have shown you already everything in the picture. One example of right external iliac artery occluded, and she was referred to us for TAVI protocol. Axis is gone here. Only left is available. I don't know whether cardiologists will do this case. If everything else is good, probably they may try. But this is what about the evaluation. Extent of calcification. That is CPR, extent of calcifications. Mention about extent of calcification. And then comes to evaluation of the coronaries, non-coronary findings, any malignancy, complete survey of thorax and abdomen. And one example I'll show you: 70-year-old male, pre-TAVI CTA, severe middle stenosis, severe left renal artery stenosis, physical aneurysm of the abdominal aorta and tortuous iliac arteries. Look at this: middle stenosis, severe stenosis, aneurysm of the aorta, tortuous iliac arteries, and this is what we have been asked to evaluate this particular case. Just I don't think they have done a procedure for this behavior. Now, the last set of slides, last set of actually a case presentation is about this particular study. Where we have done. I'll show you first the. Okay, this is coming to CT scan. Okay, this is coming to the cath angio, or probably we'll just go to first the CT and then come back to the cath angio. This lady had a very tortuous aorta and very symptomatic aortic valve stenosis, severe aortic valve disease, symptomatic aortic valve disease, and we have done the pre-TAVI CTA protocol, and look at the aorta, which is so tortuous and ectatic. Patient had also kyphoscoliosis. So this was done, and the cardiologist was really enterprising, and they have implanted a valve. That was really an excellent procedure what they have done. Just to show you how a valve looks and implantation looks. This is the pigtail catheter positioning. This is the valve calcification. You can see that valve calcification, and that is the pigtail catheter injecting, trying to locate the annulus, annular level. And this is a injection, pigtail injection, looking at the angle. And this angle was predetermined. This angle was predetermined by the software, not by CT. We have not done it. This has been done by Medtronic software. I have not done it. Then they are now implanting the valve there, and valve, self-expandable valve is partially being implanted. You can see there, and this is a fully expanded self-expandable valve there, completely implanted, very well implanted valve there. This is a pacing wire. I believe they use a pacing wire for almost all the TAVI procedures, and this is just to get the puncture site. They have done initial injection from the contralateral side to get the puncture, accurate puncture, because 14F sheath the SFA cannot take. It has to be high puncture, what interventional radiologists call as high puncture, almost over the head of the femur in the common femoral artery, so that the sheath goes in. Otherwise, the SFA will not support the sheath. So this is what is one live case what I have tried to show you. Complications. Now I think we are almost closing. Complications. A couple of points by Anup, and then we'll probably start winding up. Anup's call, please.
Yeah. So Anup, after the annular measurements, you give your inputs on two particular points. Other than annular measurements, what other measurements you would like to highlight on that, number one? And other than the vascular tree, what are the other things as a cardiologist you would like to know from us?
So, you know, I keep telling my radiology colleagues that the most important role of radiologist in the current time, and I'm not talking about 5 years down the road, in the current time, in the CT tower protocol, because this is where buck stops at you. As a radiologist, you get a CT tower protocol. We are all so much caught up with annulus, with vasculation measurement and all this. But we do need to look at extracardiac, extravascular space. Please look at every single scan that has been obtained to look for incidental findings, to look for malignancy, to look for space occupying lesions, to look for any other abnormalities, infection, whatnot. Because as a cardiologist, we are looking at these images from the vascular aspect. These images are being processed currently by the company, which looks at the annular measurement and everything else. But none of us look at things outside the heart and outside the vessel. Only you and only you are doing it. So there has been enough cases, particularly early on, where TAVR has been done in patients with metastatic cancers, which were incidentally documented after the procedure. So my humble request to all the radiologists is that while we do want to measure the TAVR related measurements and everything, please look at extravascular space with the same kind of gist that you look at in your usual CT scan. If you don't report, it goes completely unmissed, and that's a disaster. That is as important as anything else, if I may say.
Yes, here it is for the radiologists at my setup is that the non-vascular component is first reported, and then we shift our attention to the vascular tree, because as Anup has said, that is so many primary importance, and that whole onus is onto us. So we do the non-vascular reporting first. We take about a couple of minutes on that. Look for all those contraindications if they are there in the outside the vascular tree, and then we start reporting the TAVR protocol. Any other points, Anup, you want to highlight on the measurements, what he has done? One question came to me that normally when we measure the sinus, it is cusp to commissure. Any role of cusp to cusp measurement?
We typically don't do cusp to cusp measurement. There are thoughts behind in bicuspid and unicuspid morphologies, whether they can add value, but so far I don't think there is any consensus. There is good data on intercommissural distance though. So typically you are doing cusp to commissure, but when you have a bicuspid valve, then you do an intercommissural distance as well, because that gives us an idea of the overall alignment of the annulus and helps us better size the valve. So intercommissural distance is standardized. Cusp to cusp distance is still not standardized in terms of its clinical utility.
Great. Another thing of importance is, as we were discussing during a trial run, was the role of VRT images. I think Dr. Nori had shown beautiful images. The VRT images will not only show the angulation of the tortuosity of the vessels in the coronal, but also in the sagittal plane. So for all radiologists, a good single film VRT images is very vital to give them that bird's eye view as to how difficult or how easy would it be for them to go inside. Anup, your comment on that.
So, I will speak for that. I know we are running short of time. In the next maybe 3-4 minutes, let me show you what VRT does to us. And this is very crucial, both for you to report as well as for the cardiologist to see. This is very important. So this is a case we did yesterday. And I remember Dr. Hemant, we were discussing last week about this particular image. And I promised I'll show you a follow-up of what happened. So, on the report, we got this case as patient has got tortuous iliofemoral artery and extremely tortuous, whatever you call it. So it's tortuous. We know from the report it is tortuous. But it is the VRT image that you actually look at it, which tells you what is the degree of tortuosity, and in your highway, so-called, where your TAVR valve is going to run, where it takes a left turn, where it takes a right turn. So here you can see these vessels, there is not a single straight component. Pretty much every single thing is tortuous, going all the way from iliofemoral area to the infrarenal aorta, infradiaphragmatic aorta. You see how at the diaphragmatic aorta, it takes such a sharp bend. There are two 90-degree angulations as it traverses to the diaphragm, enters into the thoracic cavity. And then there's a straight portion over there, and it takes a sharp curve around here. So these kind of aorta, you can appreciate the course only and only by getting virtual 3D reconstruction. There is no other way you can appreciate, because if you are a proceduralist, if you're going to do a procedure, you need to know. And I'll tell you why it helps. So if I don't see this image, I'll show you what happens in the angiogram. By the way, I'll just show you this case so that it gives you the complete picture. This is the horizontality that I was talking about. This is the valve angle. This is the annular plane and the horizontal axis. And you see this angle is 73 degrees. So this aortic valve is very horizontal. Anything more than 60 degrees, we consider it very horizontal. And this is quite horizontal. Bicuspid valve, you can see there is the third cusp is missing. There is a joint raphe here, and severe calcification. And the same calcification you see here. What is also important for us to report, that it's a leaflet calcification. It is not an annular calcification. The annulus is free of calcium, and there is no calcium extension into the LVOT. This patient, we did a CT coronary reporting along with TAVR, which we do routinely. You can see at the middle, at somewhere in the prox to mid LAD, somewhere more towards the mid LAD, there is a complex atherosclerotic plaque with moderate narrowing. So this is the overall CT assessment that you get from the vascular standpoint, extravascular we talked about. And I'll show you the VR image. I'll show you how it works in our setup. So this is the procedure yesterday. Do a guided puncture, take a shot. We make sure we are in the common femoral. Here you can see we are in the common femoral. And watch the second image as I play. Just watch it. See what happens. See, we are pushing a wire through the needle. This wire just takes random turns. In a routine case, we would not push this wire. If it takes that kind of turn, we would stop. We would question ourselves where this wire is going. But in this particular case, I have the VR image in front of me. I see where all the arteries take the left and the right turn. So I'm very confident, and I know that wherever my wire is going, it is not coming out of a vessel. It is not going into a branch. This is the vessel. This is the patient's vessel. It is just tortuous in that angle. I know all the left turns. You can actually see how it enters into the thoracic aorta. and we have seen all that angles. It just gives us that level of confidence, which otherwise you can't get if you have not seen the VR image. This is the coronary angiogram, which is done pre-procedure. You can see the coronary artery disease angiographically is very mild. So we decided not to intervene. This is another image. You can see this is a Lunderquist. It's a very stiff wire. And once you put a stiff wire, everything becomes straight. And now you take a large sheath. This is a 14 French Python sheath. It just tracks through that wire. This sheath is not supposed to dance like the first wire, which was dancing. Why? Because now you have a very stiff wire, which guides the sheath to take a very straight path. After this, rest of the procedure is pretty standard. This image you saw, it's an annular shot. You enter into the valve. I don't know if you're able to appreciate. You see, this is the valve opening at my cursor. There is a tiny, tiny valve opening, and you just have to be lucky for your wire to enter. You can see the operator is trying its best, and it's not able to, and finally, it finds that hole through which the wire goes. Between the two images, it is 1 hour apart. You can imagine it took us 1 hour to find this place where the wire would go. This is a balloon valvuloplasty. The size of the balloon we have chosen is the minimum annular diameter that a radiologist has given us. So this is where your measurements are helpful. We take the minimal angle. You can see the calcium is being displaced by the balloon. The other important thing is this is a raw valve which is going to traverse through the ascending aorta and through the arch. So we need to be very clear that the arch is free of any atheroma or any disease. Otherwise, this valve is going to scrape the ascending aorta and the arch, which will cause disaster. It can cause stroke, it can cause vascular injury. So you can see this motion. As a cardiologist in the VRT image, as well as in the multiplane, we need to make sure we know what path aorta is taking and whether aorta has disease. And the same thing for the radiologist. When we are reporting, we report in such a way so that we get a picture of whether there is a high chance of this valve scraping the aorta and causing problem. The deployment and everything is pretty standard. You put a valve, position it where you want to, inflate the balloon, deploy it, take a push shot. You can see there is a little bit of leak around this valve. That is the calcium which is leaking. We accept this leak. And at the end, we do a groin angiogram to make sure that the arteriotomy that we have created, there is no leak, there is no bleeding. And here you can see this is the arteriotomy site here. And we make sure that there is no stenosis, there is no bleed, there is nothing. This is a case which went quite well. And it highlights the very important aspect that unless you know your vasculature and anatomy properly, you have visualized with your own eyes, it is very difficult. A lot of it is guesswork. It becomes a guesswork in the cath lab. But if you look at your MIP images, MPR images, VRT images, you take a lot of that guesswork away. And both radiologists and cardiologists need to work in synchrony to make this happen.
Well explained, I think well demonstrated also, Anup. Thank you for that. I think it's almost 2 hours of intense and very helpful discussion. Dr. Nori, Dr. Anup, it was an excellent presentation, excellent efforts taken to explain to the radiologist as to where is it that we can go wrong and what it is that we need to put on a report, which will be appreciated by the cardiologist. I think we can end the session here. Dr. Nori, Dr. Anup, Priya, can you come on the screen, guys? And Dr. Priya?
Yeah.
So she's already making the audience ready for the next one. Great. Thank you all for this wonderful presentation. Yes, Priya, on to you.
Yeah, the presentation was so good, Dr. Noori and Dr. Anup, that we just didn't realize where the time flew. Thank you very much. So next session is on 12th February. It will be related to flow imaging. We'll discuss about the technique, application, pitfalls, and clinical utility of flow imaging. Dr. Rajesh and Dr. Mahesh from Amruta Institute of Medical Sciences will be taking the topic. So see you next month then. Thank you.
Thank you all. Good night.
Very much. Thank you, Anup, for an excellent.
Thank
you guys. Thank you for having. It was a pleasure. Thank you so much. Good night, guys.
Good night.
Right.
Good night.